Bismillahirrahmanirrahim is Dr. Abid Rafiq Chaudhary, a pediatric intensive care consultant from Fatma Memorial Hospital, Lahore. And today we have in a PICU chat series talk about pediatric ICU neurocritical care in a patient who is admitted with a meningoencephalitis or encephalitis, and purely patient has status epilepticus, plenty of convulsions, and very difficult to manage these patients, especially if they have necrotizing encephalitis, and also they may develop raised ICP issues in pediatric ICU. So, how we can help these patients in pediatric ICU. The main goal and big plan for the patient is to recover out of primary disease of encephalitis while you are adapting neurocritical care strategies in a pediatric ICU, including gentle ventilation if they need. So that's the main goal and big plan for the patient. So talking about a lot of people, they ask questions about when to intubate these patients. So the most important thing, for these patients is we can secure the airway if they have severe status epilepticus, means the patient came to you a couple of times, you have given lorazepam or diazepam, and you have to load with the phenytoin, initially 15, and then you give more 10 milligram per kg, total of 25 milligram load, and still patient is convulsing. The problem in Pakistan right now, we don't have IV phenobarbital available. So we left with a two choice after phenytoin, and if the still patient is convulsing in a pediatric ICU, we have IV Liraise, or we have to load these patients, especially if they are bigger, we have to use IV valproic acid. But at the same time, if you are giving them lot of benzodiazepine, and especially if you load with them a lot of anticonvulsant, they end up by having a severe status epilepticus, and then they have depressed level of conscious. So at that time, maybe they start to drop their pressure, especially if you start them on midazolam or thiopentone infusion. So that's a clinical judgment that at what time you have to intubate. But if you are expecting very difficult patient, as I explained you, then better to secure airway and do mechanical ventilation. Because another advantage that you can deal with better with the raised ICP issues in these patients. So, and especially if their level of GCS is very depressed, they cannot secure they don't have protective reflexes intact, that's another indication to intubate these patients, in the due course. So what are the main points to be considered early? You have to remove pain, sedate, paralyze. If severely sick, like they might have, aspiration pneumonia, because a lot of times patient, they have admitted in some other hospital and they have shifted, or they may be ventilated even before, and they may have, other than the brain disease like encephalitis, they may have aspirated also. So if they are very sick, obviously you have to intubate them early, remove pain, sedate. Be aware, first control convulsion, so that you don't lose the opportunity to observe and treat fits once paralysis occurs. So before you paralyze these patients, make sure these convulsion has been controlled effectively in these patients. They may need a bedside EEG, and also you have to keep eye on blood pressure, because the way you give these patients a lot of benzodiazepine and other anticonvulsants, they start to drop their blood pressure. So that's a major issue also in these patients. So also at the same time, you have to treat infection aggressively, reverse the primary disease like meningoencephalitis, cautious fluid and balance electrolyte balance with strict intake-output charting. At the same time, lot of times we consider infection, but maybe in a pediatric ICU, you may be dealing with a hemorrhage. So they need early CT scan to rule out that problem. They might have stroke, and that is the reason, because a lot of times patient, they may not have history of fever, but they lose conscious level early and they convulse vigorously. So in these patients where there is a, not proper history of having, febrile illness, always consider stroke, and early CT scan may save your skin in pediatric ICU. Keep eye on renal functions and electrolytes, that's the bottom line in these patients. And as far as convulsion control, you have to completely abolish the convulsion in these patients. So you have to control fits aggressively with IV phenytoin, as I have explained. 15 plus 10 you can use. Again, the same problem as discussed before. We don't have IV phenobarbital, so a lot of times these patients they are convulsing. So I load them, especially if they are smaller children, like less than 4 or 5 year old. I really load with them NG phenobarbital very early. I give them like 15 milligram per kg, and syrup Debritone is available, and 20 milligram is available in 5 ml. So if someone has 10 kg weight, so it need to be given 15 milligram per kg means you have to load them with 150 milligram. So that is a lot of volume, but you have to deliver that through NG. And then you can start maintenance, because in the next couple of days that will take care convulsion very effectively. Because we have seen over the years the barbiturates are very helpful. Obviously you can load them with IV Lirace after you have failed with the IV phenytoin, or you have Epival available in Pakistan as well, especially if you are dealing with adolescent kids. Then with keeping eye on the LFTs, you can load them with the Epival, and you can give them the maintenance. And ultimate, if you are in a difficult situation and the status is going on, very early you have to start midazolam infusion and build up. We build up very quickly midazolam infusion, because midazolam infusion to stop fits can go up to 20 microgram per kg per minute. Usually we start with 3 to 5 microgram per kg per minute and build very quickly, so that, but at the same time, once you are on 10 to 12 microgram per kg per minute of midazolam infusion, you have to give them fluid, and obviously you cannot give them much fluid, so you have to put them on vasopressor because your blood pressure is dropping. So definitely if you are on high dose midazolam infusion, keep eye on blood pressure, because we know that one cerebral perfusion pressure in any patient, it depends on the mean arterial pressure minus ICP, and for some reason if your ICP is increased, obviously your cerebral perfusion pressure is compromised. So if you can bump up your mean arterial pressure by giving fluids or most likely inotropes in these neurocritical care ICUs, then maybe you can buy some time to treat ICP. So it's one way of dealing with raised ICP and improving the cerebral perfusion pressure of the patient. So ICP management, you have to do with the IV mannitol or hypertonic saline. Mostly we prefer hypertonic saline. Dose is 6 ml per kg. Quickly you can run over 15 to 20 minutes, and you can repeat also if there is no response. Mean blood pressure has to be increased initially by volume or later on by vasopressor like dopamine or epinephrine. Usually if I start epinephrine, I start with 0.03 microgram per kg per minute, and you can build up slowly. Mostly can't give lot of volume, so you left only with to achieve your better mean arterial pressure, to achieve your better cerebral perfusion pressure, and to deal with the ICP, you may be left with the other than giving hypertonic saline, you have to give them inotropes to increase your blood pressure in these cases. So what is the job of pediatric intensivist? Obviously, the primary injuries like infection or neuronal injury mainly focus on prevention. So mostly we, as an intensivist, we have to contain the cerebral edema, we have to control the fits, and as well as brain swelling we have to reduce, because ultimately it can progress to systemic inflammatory response syndrome and multi-organ dysfunction syndrome. So what you need to, by doing neuroprotective strategies, you have to reduce edema, ischemia, and hypoxia in these patients. Because we know there are two types of cerebral edema. One is cytotoxic and other one is vasogenic. In vasogenic, mostly there is blood-brain barrier disruption and there is increased fluid. So, in these, ultimately, any kind of cerebral edema that can lead to ischemia and brain injury. So, you have to be aggressive in treating cerebral edema patient, because ultimate cerebral edema can lead to different kinds of herniation syndrome, including cingulate, central transtentorial or lateral transtentorial, like uncle herniation, in this case you can see, and also you can have downward like tonsillar herniation, or even if you have done decompressive craniectomy, you can have also transcranial herniation, like in this picture I have shown. So what we can do, we know that one in this picture you can see, in the y-axis there is a ICP, and there is a x-axis, that's a brain volume, and it can be cerebral edema. Initially there is compensation, but later on you have a decompensated phase of cerebral edema, and obviously your ICP start to rise in these patients. So what is the appropriate cerebral perfusion pressure in any patient in pediatric ICU? It depends on the age. If age is less than 4 years, you need to achieve CPP like 50 millimeter of mercury, and the age if higher, then you can achieve around 60. Normally, in any patient, there is a cerebral autoregulation active, and you can see here, this is a cerebral blood flow, and on the x-axis there is cerebral perfusion pressure. So if on the long range, you have maintained cerebral blood flow and cerebral perfusion pressure because of the cerebral autoregulation, but if you have the balance tilt on the left side, if cerebral perfusion pressure is dropping, or balance tilt towards the right side, cerebral perfusion pressure is increasing, then in these patients, if you are on the right side, you can have increased cerebral blood flow leading to high ICP. And if you are on the left side of cerebral perfusion pressure curve, where you have more risk of ischemia because cerebral blood flow is on the lower side. So in this, we can talk about now what are the factors which can, affect the cerebral blood flow. And the most important thing is the effect of oxygenation and ventilation in these patients. So increasing cerebral blood flow can increase with hypoxia. Normally, that's a range 75 to 100 of PO2. You have a stable cerebral blood flow. But once there is hypoxia, especially if you are less than 50, then your cerebral blood flow start to increase, because there is a vasodilation of blood vessels, and you have increased ICP with increasing hypoxia. As far as we can discuss about the role of CO2 in cerebral blood flow, that's also very important, because we know CO2 affect the pH, and level of acidosis in blood also causes vasodilatation. So if for some reason, like normal CO2 is like 40 to 40 in a patient, and then you have a normal cerebral blood flow. But for some reason, if your CO2 goes high, then you have a very high cerebral blood flow, and then you have a high ICP. At the same time, if you drop CO2, especially less than 30, then you have a brain ischemia at high risk, because brain experience vasoconstriction of blood vessels once your CO2 is less than 30, and obviously then your cerebral blood flow is low, and brain can get severe hypoxia. So, you have to maintain oxygenation and CO2 in a normal range with a neutral environment for pH. In this picture, we can discuss about, there is a relation of cerebral blood flow with ischemia duration. So, if for example, you can see someone can normally you have if you have normal like 18 ml per gram of brain per minute of cerebral blood flow, for 4 hours, then you get ischemia. But at the same time, you can get ischemia early in 1, 2, or 3 hours if your cerebral blood flow is less than 10. Like here you can see if your cerebral blood flow is 10 ml per gram of brain per minute, it can lead to ischemia in just over 2 hours time. So it depends on how severe is your cerebral blood flow is compromised in the patient. So, as we have discussed before, normal oxygenation, avoid hypoxia, and you have to keep CO2 35 to 40, and avoid hyperventilation until it is necessary, like you are going for CT scan, or you suspect immediate coning or herniation. You have to intubate these patients early, especially if they have very depressed level of conscious, and they are not protecting their natural airway, and you have to maintain the blood gases, and then also you can manipulate the cerebral blood flow with the ventilator by dropping the CO2 like around 35. And also very importantly, you have to achieve normal or high sodium. Sodium you have to push like above 145, above 145 to 150, and that give you high serum osmolality, and it can take the brain edema, it can improve the cerebral edema in these patients. Also, in this slide we can see what we can do. We can reduce the cerebral blood volume by cerebral blood flow regulation with the metabolic component. So avoidance of things that can require brain to use more oxygen. So also there is a relation. So if you drop cerebral metabolic rate, ultimately you are dropping cerebral blood flow, and you are controlling a little bit raised ICP in these patients. So optimization of sedation and paralysis is very important. Normally we use morphine, but nowadays, previously we were using morphine, but nowadays we are using mostly in these patients fentanyl plus midazolam infusion. And whenever you paralyze, make sure your fits has been controlled, and bedside EEG is preferably available in these patients, because you have to rule out the non-convulsive status also in these patients while you are dealing. As far as we have discussed before, there is a role of increasing the mean arterial blood pressure to deal with the raised ICP and improve your cerebral perfusion pressure, and avoid giving more fluid because it's going to exacerbate your cerebral edema. Hyperosmolar therapy is a cornerstone, and the goal is to creation of osmolar gradient, and because of the mannitol disturbance of electrolyte and plenty of diuresis, we prefer to use hypertonic saline. There are different concentrations available, and mostly we use 6 ml per kg of 3% hypertonic saline, and it can raise one dose, raise the sodium by 3. So you have to increase your sodium like above 145, and that can give you the better osmolar gradient, and can take the cerebral edema, take care better in these patients. So if you are dealing with a very sick patient, maybe you have to go for barbiturate coma if you are unable to control convulsion in these patients. So you can put them on thiopentone, barbiturate coma like thiopentone infusion, and it's preferred for long-term use, and you have to achieve the burst suppression on bedside EEG, but keep eye on the blood pressure, because most of the thiopentone or pentobarbital barbiturates, they have direct cardiotoxicity as well. So in a summary, if you are controlling these patients in a pediatric ICU and they have refractory status epilepticus, you have to intubate, ventilate as indicated, control fits aggressively, sedation with midazolam, and pain removal with fentanyl or morphine, and keep ICP low, less than 20 with the hypertonic saline therapy. Keep your sodium high, and ultimately in very few patients you have to go for thiopentone coma. The most important thing in these patients, you have to keep informing the parents about guarded prognosis, because a lot of times these patients, they may not have, even if you can save them, they may not have a good neurological outcome. Thank you very much.